Good morning, everyone, and welcome to today's Health Action Council webinar titled Bending the Diabetes Cost Trend, hosted by Abacus Health. My name is Florian Keat. I am a member experience leader with Health Action Council, and today we're joined by Dr. David K. Ahern, Assistant Professor of Psychology at Harvard Medical School and the Director of the Brigham and Women's Hospital Program in Behavioral Informatics and eHealth. From 1992 to 2000, Dr. Ahern was the founder and director of the Behavioral Medicine Service at Massachusetts General Hospital, where he provided clinical care, monitoring of interns and residents, clinical research, and consultative services. During that time, he also served as Chief Science Officer for the Abacus Group, which focuses on, among other things, diabetes and hypertension. He has served as Special Advisor for the Health Communications and Informatics Research Branch of the National Cancer Institute, as well as the Connect to Health Task Force for the Federal Communications Commission. He has had a distinguished career of clinical research in behavioral medicine and the development of behaviorally based e-health applications for health promotion and chronic disease management. Today, Dr. Ahern is going to inform us how engaging diabetic populations in a comprehensive diabetes management program can deliver clinical and financial results for plan members and sponsors alike. In his presentation this morning, Dr. Ahern will also share the results of a study summarizing a decade-long implementation of the Abacus Health Diabetes Care Rewards Program. He'll cover which engagement techniques work best with various populations, the clinical impact for plan members, and the medical and pharmacy impact for both employers and payers. Before we begin, I want to remind everyone, if you have any questions, please use the chat box located on the right-hand side of your screen. I will be monitoring the chat box and will pause at the end of today's presentation to respond to your questions. If for some reason the chat box is not working, or if you run into any technical issues, please feel free to email me at fkete@healthactioncouncil.org. This webinar is being recorded and will be available to Health Action Council members on our website under the Member Center section at healthactioncouncil.org. If you have misplaced or forgotten your login information, please feel free to reach out to our staff and we will be happy to help you. This webinar is pending for both SHRM and HRCI credits. We will hold a poll at the end of the webinar for those Health Action Council members who would like to receive credit upon approval. And lastly, you will receive a survey by email immediately following the presentation regarding today's webinar. Please complete the survey. It's really brief so that we can continue to provide you with high-quality educational content you are seeking. And with that, Dr. David, the floor is all yours.
Thank you, Florian, for that kind introduction. I really appreciate the opportunity to speak with you today, so welcome. First, a little bit about Abacus Health. As Florian indicated, I've been involved in research and clinical care in my career, as well as been an entrepreneur working with colleagues to create Abacus Health, which was founded in 1988 as a research and development firm. And our focus is really bringing behavioral science and the evidence from medical research to the development of technology-enabled solutions to address health problems. So Abacus really is an e-health company focused on managing chronic conditions and also addressing the financial risk involved in managing chronic illness, particularly for payers, employers. And also a good bit of our work has been around the factors that lead to greater engagement of patients and members from health plans in these kinds of programs. I'll mention that for about a decade, I was involved at Abacus in overseeing our small business innovation research program. We had a series of funded research from the NIH that helped actually develop the content of the program that you're going to hear about, the Diabetes Care Rewards Program. So I'll talk a bit more about that. The Health Action Leadership Council had indicated that many of its members, many of you, I'm sure, on the call, are dealing with the diabetes epidemic. And indeed, we have an epidemic. This is a major health problem that burdens a significant percentage of the population, and we continue to see challenges despite actually a fairly robust evidence base about what's an effective way to manage diabetes. But in part, it's due to this obesity epidemic that sort of serves as a catalyst and stimulus for increasing the rates of diabetes as we move forward into the future. So having a comprehensive approach to this problem, we believe, is absolutely essential. And if you just look at some of the diabetes statistics, these will not be that surprising to you all that have addressed this issue. That when you look at the standards of care, which, as I mentioned, are fairly well established for optimized management of diabetes, less than 10% or only about 10% are adherent to all of those care standards over time. And one thing you'll hear from me, and I recognize from my work in this space, is that diabetes is a very difficult illness to manage, particularly over the long term. And for most patients with diabetes, with a few exceptions, once diagnosed, they're likely to have to live with this disease for the rest of their lives. So it's really about ongoing management of a significant condition that has impact on overall health, work productivity, costs obviously for the healthcare system and payers, and the like. And part of the other characteristics, this non-adherence with medication. Often when I talk to people about the work I do in the diabetes space, people say, well, why don't patients take their medications? And the fact of the matter is that there are many reasons why people are non-adherent. And it changes over time. It's different for different people. And as I mentioned, with diabetes and the complexity of the illness, it's often quite challenging to remain adherent over the long term to prescribed medications. And then the other factor we've found is that as diabetes progresses, as a person has diabetes over a longer period of time, they can develop comorbidities or other chronic conditions such as hypertension, which is one that we focus on also at Abacus because of the frequent comorbidity of diabetes and hypertension. And as you add more conditions and as people age with more medical conditions, the management challenges increase. And then when you look at the cost of diabetes, this is obviously an incredible burden on the healthcare system, on payers, on employers, and on individual members with out-of-pocket expenses in terms of the cost of diabetes. So we'll sort of talk more about sort of the challenges that this condition presents, but the ways in which we believe it can be optimally managed. And you'll hear me talk about this in a comprehensive way, that we think that there isn't a single approach or intervention that standing alone will bend the trend on diabetes. It really requires a comprehensive approach. So what Abacus has developed is a program that does use a behavioral science-based reward system as part of a core component of it. But fundamentally, what the approach promotes is closer engagement of a patient or a member, in this case of a health plan or an employer, self-insured employer, with their provider. So we look to encourage members to really become more engaged with their provider over time. It sort of speaks to the point I made earlier that this is a chronic illness. People will likely have it for their lifetime. And the more that they have an ongoing, meaningful, productive relationship with a provider, the greater the likelihood they're going to be able to sustain adherence to the recommended care guidelines. And so we believe strongly in that perspective, and you'll hear more about how we promote that through a provider confirmation form where there is an absolute documentation of members doing the care guidelines or adhering to care guidelines as recommended and provided through their provider visits to really close what we call the gaps in care. And then we'll share data that we've looked at around the areas that are the most important in diabetes management. And then obviously I'm a behavioral scientist and informaticist by training. So our focus at Abacus has really been to focus on behavior change assessment and planning and bring the best behavior change science to this area. And we'll talk about some of the approaches that we've used to do that. And then medication management, as I mentioned, non-adherence is one of the major factors in poor diabetes management. We have become increasingly committed to identifying some of the barriers to optimize medication management. And we work closely with our clinical pharmacist team that we've now brought into the Diabetes Care Rewards program because of the complexity of the conditions, the complexity of medication regimens, the cost and burden of these meds. All of that has to be addressed comprehensively, and we believe strongly that a clinical pharmacist has the ideal training and experience to help do that. And then a final component, which is emerging, and I'm sure many of you have heard from other groups that do this kind of work in remote monitoring or glucometer monitoring, blood glucose monitoring. We also have spent a good bit of work, and I've done a good bit of research in my career in looking at remote monitoring and how that can help in improving self-management of diabetes in this case, but also can be used as part of a collaborative care coordination process with providers and with our team of diabetes educators to make sure that when patients' blood sugar levels go high or low in areas that are increasing risk, that we're able to respond appropriately. So I talked about provider engagement to care standards. So what are the care standards? So the ADA has identified these 5 specific care standards for optimal diabetes care: having an annual eye exam, foot exam, lipid panel, urine protein test, and then a semi-annual or twice yearly A1C test. So those really collectively define the minimum requirements. But completing all those standards, and again, maintaining those standards over time has been shown to reduce the risk of hospitalization and the reduce costs associated with a more optimally managed diabetic condition. I mentioned the behavior change component of the Diabetes Care Rewards Program, the Abacus solution. We've created what we call the Diabetes Health Action Plan. And this is a behavioral assessment that is protocolized, that includes motivational interviewing. It includes the target areas that we recognize are commonplace in non-adherence to recommended guidelines and to medication. And this is done through a diabetes health educator or nurse educator in our program, or a clinical pharmacist, depending on the complexity of the case that this member may bring to the table in terms of comorbidities. So it's really assessing members' knowledge of diabetes, lifestyle discussion and recommendations around improving lifestyle. So obviously, diet and exercise are critical components to optimizing the management of diabetes over the long term. We all have challenges in managing our diet and exercise regimens, but they're absolutely critical in diabetes, and those are addressed in this process. And then a specific care plan is created through that Diabetes Health Action Plan interview, which is then made available to the primary care provider for review and sign off. So this is part of how we engage the primary care provider or the physician of record, the provider of record, in their work with us around managing the diabetes challenge for their patients. So there's a personalized plan for every member based on needs and condition, a checklist that's sent to the primary care provider, and the members who complete this plan are better prepared to have deeper conversations with their provider. So it actually serves as a resource to the member to have a more effective, optimal conversation with their clinician or their provider. I've talked about medication management. This is really where Abacus, I think, has shined, and we spent a good bit of the early years, a decade ago, when the program first began, in really thinking about how could we create an incentive that would be meaningful but relevant for the person with diabetes. And what we realized that made the most sense, we tried a host of incentives and continue today using different kinds of incentives, but the most effective incentive is to reduce or to eliminate copays on diabetic medication and supplies. You really get a twofer out of it. You get the reinforcement of the behaviors that are related to care standards I'll talk about that in a moment, but you also increase the likelihood that patients will be able to have access to the medications that were prescribed for them that would help them manage their diabetes. So the key is that only members meeting all of the program requirements, those 5 requirements I listed, are eligible for incentives. So when they walk into any pharmacy in the United States, a CVS, a Walgreens, Rite Aid, what have you, we are able to have that claim adjudicated automatically based on data that we provide to the PBMs and to the pharmacies so that the member can receive their diabetes medications and test strip supplies for no out-of-pocket expense. So I've often said there's no more powerful incentive than to have that process occur in real time and to support adherence. And this adherence, as the evidence indicates, directly impacts outcomes. And we'll talk about what we've found in our program. And this is just a testimonial from one of our employees, members from National Vision, that really has benefited from this approach. And then I mentioned the glucose monitoring. Again, you're seeing a lot more of this. I'm a technologist and informaticist. I very much believe in the use of remote monitoring and devices and sensors. But we have a particular approach at Abacus that may be a bit different than what you might have heard from other organizations that are really driving hard on this dimension of diabetes management around glucose monitoring and control. It's a bit of a mixed picture. It's challenging to do, number one. It requires that you have some capability to work with technology. And again, as I mentioned, do a lot in the technology space, and I recognize it can be incredibly challenging for people to use these devices consistently over time and to be successful in managing these devices and the technology behind it. But we also know that it's increasingly becoming available, easier to use, easier to engage. And we've got several projects underway using remote glucose monitoring as part of our approach. What we recommend, though, to our employer clients in particular, is that we identify those members that are at the greatest risk, number one, so we do risk profiling. And we also have a method where we determine where we think that adding remote glucose monitoring will actually improve care management. So it's really looking at who's likely to benefit the most and who's at highest risk. That combination is how we determine how we apply this particular kind of approach. So not all patients not all members rather, who are in our Diabetes Care Rewards program do remote glucose monitoring and control. Although it's available and can be available, we actually are trying to manage sort of the additional costs of this and also looking at the outcomes that can be obtained by identifying those who have the greatest potential benefit. Abacus has spent a lot of time over the last decade in really focusing on the member experience. I mentioned our focus on engagement. So we really, have this, attention to how do you engage people. And there are a variety of different channels. So email, text, mailing to the home, telephonically. We do all of those things, and we try to determine what's the preferred method for each member and what's the most effective method over time for each member. So we do a bit of predictive modeling to determine how to best put together the package of engagement strategies for each member in our programs. And that's how we, I believe, achieve the kind of engagement that we get by doing this kind of communication approach. And then obviously the adherence, when members fall out of adherence, that is, they no longer are adherent to those care guidelines, we are able to turn off that incentive, but we also remind members of when their care activities are coming due. So there's a lot of preemptive work to try to keep people engaged and not have people fall out of adherence. We want to maintain adherence as much as we can, but we use that incentive instrumentally. That's part of being a good behavioral scientist. So I've given you at a high level, not all of the details, but at a high level, how Abacus approaches the diabetes care management challenge from a sort of comprehensive perspective. And now what I'd like to do is say, okay, over the last decade, we've been able to gather the data from our clients. So Abacus, in addition to its delivery of this comprehensive diabetes care rewards program, we also have built an analytics and data infrastructure capability. We're actually collecting all of the claims, the medical and pharmacy claims from the third-party administrators, the TPAs, the health plans, and we work with many for all of our clients across the country. So I've had a lot of experience, and we've got I think a really good IT team that has built a data warehouse, not only for the management of our book of business to deliver the services I just described to you, but also to work with me as the research scientist around how do we organize these data so we can actually look longitudinally retrospectively, but longitudinally, and then hopefully prospectively as we move forward in actually looking at the impact over the last decade. And so we've spent really the last year and year and a half in sort of organizing our data warehouse to not only continue to service our clients every day and our members, but also to look at it from a research perspective. So I'm going to give you, and this is ongoing, as you might imagine, was a pretty significant lift to do this, and you'll see by virtue of the numbers. But just to give you sort of the overview of the research study pool. So this is the high-level view of the variety of industries that Abacus has engaged in terms of clients. So we have Fortune 500 companies, we have financial services, food services, municipalities. We have a pretty significant experience base in the healthcare and health hospital system vertical. So we have lots of hospital systems. We cut our teeth on the hospital systems here in Rhode Island in our earlier days and have been now delivering the Abacus Diabetes Care Rewards program to hospital systems across the country and a host of manufacturing companies as well. And we do have the municipalities are organized in cooperatives. So we have a lot of smaller towns and cities that are part of purchasing groups that we manage, that we provide the Diabetes Care Rewards program through to that management cooperative. The typical employer is greater than 500 employees, including dependent spouses and dependents. We're national as well as local in our dispersion. We have a balance in terms of male and female, although slightly higher male, probably with the manufacturing and some of the other tech companies that we have in our current book of business. The original pool was 14,245 members with diabetes that were part of the original pool for us to look at from a research point of view. And I'll add more detail now about how we ended up identifying that number. They had to be members who were eligible and participated or eligible but didn't participate and had 24 months of continuous medical and pharmacy claims data available to Abacus. So as you probably know, in this world, we don't always get all of the data. It doesn't always come when we need it. It's the real world management as a sort of third-party vendor of this service. We had to make sure we had the continuous 24 months in order to be able to do the comparison. So we identified of those original 14,245, 3,318 members from 2010 to 2018 who were eligible enrolled or eligible to enroll but did not enroll. And we used a propensity score matching technique, which is the sort of common approach now when doing scientific comparative research, and you don't have the opportunity to randomize people to conditions, treatments, or interventions. The propensity score matching approach is the recommended approach to do that, to attempt to try to manage the potential imbalance that you have in groups, those that are elected or volunteered to participate, given it's a voluntary program in the Abacus Diabetes Care Rewards program, both versus those that were eligible but chose not to. And we did an analysis of outcomes by their program status of enrolled versus unenrolled. So here's just a slide that summarizes the total number of members. As I mentioned, 3,318, 1,659 in each of those two cohorts. The number of member months covered by that population is 39,816, average age of 54, 42% female. The total number of medical claims for that cohort was over 375,000 claims, and the total medical costs associated with those claims for all of those members, the 3,318, was over $74 million over the decade. So what we did with this data was say, okay, what we do with Abacus's program is focus on decreasing gaps in care, decreasing the service use of high-cost services such as hospital admissions and hospital days, improve clinical outcomes, particularly looking at HbA1c, and also looking at the cost dimension, obviously a really important primary outcome for our payer clients who are interested in improving quality but also mitigating or controlling the cost trend. So I'll step through these now and give you what we've determined to be the outcomes based on on the results from this propensity score matching technique. So when we looked at the gaps in care, I mentioned to you the HbA1c semi-annually, the lipid test annually, the microalbumin test annually. When we looked at these two groups and looked at the rates in which they had these tests, this is again looking at claims data. So this is through the administrative claims data. We had a 24% improvement in HbA1c testing to that semi-annual test, a 6% increase in lipid testing, and a 22% increase in microalbumin testing. So both the 24% and 22% are statistically significant. The 6% didn't meet the less than 1%, 0.01 level, which is what we said in this study for minimizing experiment-wise error rate, as it's called statistically. And the reason that is lipid testing has really become a pretty common standard in primary care for cardiovascular risk reduction, as most of you know. So we didn't anticipate necessarily as significant an improvement there, although we do see an increase. But the HbA1c testing and microalbumin are really critical dimensions that need to be done for optimizing diabetes management. And as you can see here, we had some significant results there. This was staggering to us. We saw a substantial reduction in hospital admissions and a corresponding reductions in hospital days, 65% on admissions and 67% on days in the enrolled versus the unenrolled groups. So here we definitely show a reduction in those high acuity services. And the management of diabetes, the goal is to reduce the complications that lead to high acuity service use, ER visit, hospitalization, hospital days. And for those of you that know the diabetes field in terms of how people end up with these complications, it's not always necessarily a specific diabetes-related event, such as a hypoglycemic episode, although those certainly occur and bring people to the ER. It's often related to secondary complications from cardiovascular disease, unmanaged comorbidities. You see those driving a lot of these high acuity services. And we believe that that's part of what we're seeing, particularly over time. So this is a 12-month period. I should have made that clear. So we're looking at the post period relative to a 12-month pre-period where we did the matching. So we're looking at post enrollment in the Diabetes Care Rewards program versus those that were eligible and matched but not enrolled. And I should have mentioned they're matched on age, gender, another variable called the Alexa Hauser Readmission Index, which is a standard Agency for Healthcare Research and Quality measure of comorbidity burden. So it actually measures, it's a weighted index of how much comorbidity you have. So we matched on that, as well as region of residence and baseline costs. We then looked at the HbA1c values. HbA1c is a variable that can change dramatically over time, and it can vary a lot. So it's a difficult index to look at sort of the raw values, if you will. So often what is looked at in terms of control is cut points on HbA1c. And we looked at greater than 9.0 as the cut point. So looking at those members who really had HbA1c levels that were in the unmanaged diabetes range, and how successful were we in moving the population of those members to an HbA1c level less than 9. And we found a 20% decrease in members with HbA1cs greater than 9 in the post-intervention period. And as I mentioned, with the Diabetes Health Action Plan, the goal is to really help them improve the management of their diabetes and therefore their HbA1c, their blood sugar, through diet, through exercise, through taking the prescribed medications appropriately, and we'll talk about that momentarily, as ways of really getting HbA1c under control, blood sugar under control, and the remote monitoring approach as well for those high-risk members that are enrolled. We then looked at a key metric, obviously the ones that I'm sure many of you are going to be particularly interested in, is what happened to costs. These costs trended the costs that we saw, the reduction in service use. So obviously high costs associated with hospital admits and days. We saw a 12% reduction in pharmacy costs, although in many cases we actually see increases in pharmacy costs in some of our accounts, which is not in itself a negative finding when we look at some of our accounts, because the goal is to promote greater adherence. And we'll show you in a minute how we found that in one particular example. In one use of a diabetic, anti-diabetic medication, We actually want to increase adherence. Therefore, we want people to make sure they fill their scripts and take their scripts as prescribed, and that can lead to higher costs in the pharmacy. And also, obviously, we're seeing, and most of you know this, we're seeing an increasing trend in the last 3 to 5 years, 3 years in particular, in the cost of diabetes-related medications and supplies, including insulin. So we're tracking that because we obviously know we need to bring value to our customers in terms of the cost management piece. And we believe in a value-based pharmacy model where you may even pay a little bit more as long as you get people to take these medications and they have an impact, you can get better overall outcomes. The real key for us is the medical costs. We believe that if we can reduce the medical costs, regardless of what happens with pharmacy, we're going to be in a better position because those medical costs often include the higher cost acuity services of hospital admits and days. So we saw a 40% reduction in medical costs across this cohort. We then also looked at I mentioned the medications. Here we looked at just the increase in prescriptions for anti-diabetic medication. So again, where the program, as you heard, is designed to encourage members to engage with their doc. So when you go to your physician, oftentimes for whatever it is, whatever service you get, there's a potential you're going to get a script. There is an increased likelihood, if it's appropriate, hopefully, ideally. And so when we have these patients involved with their primary care docs or with their physician providers, we want them to make sure that they're getting the medications that optimize their diabetes management. So we look at prescriptions. We saw a 30% increase relative to a 9.6% increase in the enroll versus the unenroll in this post-intervention period. So we're getting an increase in diabetes prescriptions, particularly for those individuals with HbA1c levels and diabetes that's not optimally managed. So you, again, getting an increase in diabetes medication use. We then looked at possession ratio because it's really specifically about are these members taking the medications that are prescribed, and are they taking them at a level that would be considered adherence. So we looked at improvement in possession ratio. So possession ratio is a metric used in the pharmaceutical world, pharmacy world, to assess adherence to medication by looking at the scripts fulfillment rates. And we have that data, and we look at that data through the program. We had a 7% increase in possession ratio across the full cohort in the enrolled versus a 2.9% in the unenrolled. So we did see that, and this is just taking one of the major anti-diabetic medications currently prescribed. We're looking at all of them as part of the study as we continue to do our analysis to see how it's working across the full range of anti-diabetic medications. And then we looked at the possession ratio on average in the post period for the enrolled versus the unenrolled, and found that the average possession ratio for the enrolled members was above the 80% cut point typically used to register adherence relative to those that are unenrolled that were at 67.5%. So overall, we are seeing the kind of trends in these data that are logical based on the hypotheses that we had originally in creating the program, is that we want to reduce or fill in the gaps in care, improve clinical outcomes, reduce or control costs appropriately across the range of different costs to create a more value-based approach to managing diabetes. So diabetes will continue to create costs for the healthcare system, costs for you as an employer. The question is, how do you manage those costs, and can you get the value for the dollar you spend? We're very much a believer in that we should get more value for every dollar we spend in healthcare. And to do that in diabetes, you have to do better management. It has to be comprehensive over time. So this is my final slide, and I think we'll have more than enough time, I think, for Q&A, and I hope we can do that with the remainder of our time. And so really getting back to the fundamental questions we asked in this study, did the program reduce or close gaps in care? And the answer is yes, it did, for those that are enrolled versus unenrolled. Were we able to reduce sort of the high acuity HbA1c patients, less than 9? We were. We were also able to reduce admissions in days, which was really a major metric for us in the program. And we also saw that in the compliant members, I mentioned this sort of sub-analysis. We did a a post hoc analysis, as it's called statistically, in those members who were compliant to the program for more than 120 days. When we actually measure every day for each member in the program whether or not they're adherent to all of those care guidelines. So they're either adherent to all of them or they're not adherent on a given day once they're enrolled. And we track that over their time in the program. And we looked at the rates of adherence, and the median is 120 days. So 50% of the population are adherent for 120 days, and we use that as a cut point. When we looked at that analysis, that sub-analysis, it was about 1,330 of the members enrolled, and their counterparts that were eligible but unenrolled. We found a $400 per member per month difference in lower costs in the enrolled members versus the unenrolled members. So this is a group that would be the compliant members based on our Diabetes Care Rewards program set of compliant metrics. So that's a sort of follow. I'll add one more since we have a little bit of time. Again, I said this is ongoing analysis. We have a subgroup of that original 3,318 that had 24 months of data. So we looked at the full 24 months. And this was about 1,200 or so members who went beyond the 12 months post, had an additional 12 months. So when we looked at the 24 months, we had a similar pattern of results that remained in terms of what I present here. So this would be a subgroup, and it's a sub-analysis, but we plan to continue to look at sort of the long-term benefit of this, because we have members that have been in the program for 10 years. When we go back to our original first account back in 2008, 2009, and we believe that over time, we will continue to see increasing benefits to those members that have been able to maintain optimal diabetes management for the long term. And that's really very gratifying, and it's what we hope to deliver to our clients. And clearly, fundamentally, we want these members to be able to have the benefit of the quality of life that comes from being optimized and managing their diabetes. So with that, Florian and Rick, I can pause there and see if we've gotten questions, and glad to answer any and all.
Sure, Dr. Ahern. This is Florian. Studies that I've read show that there's a greater chance of affecting lasting change when you utilize 4 or more strategies to impact the desired change, and that's what your presentation sort of supports. But the first question we have is, for members that you mentioned to be considered adherent for 120 days, can you recap the savings that you saw?
Absolutely. So for those members, we looked at their overall costs. The pattern was similar to what I showed here for the full cohort in terms of pharmacy, medical, and total costs. Although the pharmacy costs were slightly higher, and that's not surprising, as I mentioned. When you look at compliance, obviously these folks are doing all those 5 care guidelines. They're going to their doctors regularly. They're using more prescriptions for anti-diabetic management, and they're filling their prescriptions. Therefore, they're more adherent. So you're going to have higher pharmacy costs. But then we looked at the delta around the medical costs being lower. So the total cost, when translated into a per member per month savings for that compliant group, was $400 per member per month differential between the enrolled versus unenrolled in that compliant group. So that's sort of what we believe is a number that we shoot to do, because we're obviously constantly working on getting people enrolled. So even if somebody doesn't enroll in the first 6 months, we still continue to consider them a part of the diabetes membership for that plan. We need to work diligently at trying to get the message across, get them engaged. And actually, I should mention, and when we do our book of business analyses for a given account, we actually look at the total diabetes population, not just the members who enroll. And that's been historically the case, because there's a rationale for that. If we didn't do that, you end up having a selection bias. There's no question that we select a certain strata of the diabetes population in the Diabetes Care Rewards program, because every intervention program, whether they tell you that or not, has a selection bias. It's going to be those people who obviously are willing to engage, want to volunteer, may have a host of reasons why, either their family member, their own condition, their doctors recommending it, that they find the appeal of the program. Whatever the reasons, that ends up being a selection bias. So without having an ability to do what we did here with a propensity score matching and have an apples-to-apples comparison, you're always going to have that selection bias. So the way that we handle it in our book of business analyses is we actually look at the total diabetes population costs. And what we believe what this study will support is that of the members we actually engage, we reduce their costs, we engage them more, they reduce the gaps in care, they in turn change the full trend for the population, because many of these people are in the moderate to high acuity range. They're the cost drivers. They're not necessarily the sickest people. I mean, if you've got renal disease, obesity, cardiovascular disease, diabetes, hypertension, had a transplant, you're probably not, and we have a few, but you're not likely to enroll in this program. But you're going to be a huge cost driver for that employer. But those are the really highest cost group that can be challenging to engage in any program. And we work with a number of accounts that offer, case management services, and a host of, one of our large tech companies with 60,000 members has a host of services. And we know that they end up going into more case management because they have multiple comorbidities, not only diabetes, as I mentioned.
David, I have a second question that someone asked. Can you explain the importance of earning the co-payment incentive rather than just making a plan design change for all diabetics with your PBM?
Sure, that's a great question. So this is where I get to be a behavioral scientist and put on that behavioral science hat and say, all of us engage in activities for a specific reason. We often don't know what that reason is, but it's a reward or it's an incentive or it's reinforcement in some form, whether it's for monetary gain, whether it's for social approval, whether it's for internal belief that this is the right thing to do, and we do these things. We are human beings. We're going to behave to seek rewards and incentives. So tying the reward, that copay waiver, to the behaviors that actually are critical to optimizing diabetes care makes a whole lot of sense, I would think. And the reason we do it is for just that reason. It does do precisely that. It kind of gives the message that, sure, we should all do the right thing to take care of our health. And I don't know how many times I've heard people say, why don't people do the right thing? Well, we're human beings. We don't always do the right thing in the sense of how you manage your health. And putting incentives in place that make it easier to do it because you're getting a reward of some form is a logical, scientifically proven way to do it. And then over time, the benefits of health, of having a healthy lifestyle, the quality of life. And I got to tell you, the most recent focus on, end-stage diabetes, the complications of end-stage diabetes are horrific. For anyone that has worked in clinical settings and hospitals, I have my whole career, it's not something you want to have. And anything you can do to avoid that is something we should do. And in fact, we shouldn't be doing amputations. We shouldn't be having people have to have, renal disease and transplant because they've had 30 years of uncontrolled diabetes. I mean, that just is something we should not tolerate in our healthcare system. And we've got to really drive hard to do that. And yet at the same time, we have to understand how difficult a disease this is. And so you need to balance sort of the desire to, make sure people do the right things by recognizing that isn't always it isn't the easiest thing to do in most cases. And you need to set up a condition so that people are likely to do it, will do it, and then reap the benefits, and they're shared by employers and health plans and communities.
So I have a third question, Dr. Ahern, which is remote monitoring of glucose is sort of a newer market technology. Can you expand on the importance of including a remote monitoring component to the program?
Sure. As I said to you, we do provide that as part of a solution of the Comparative Diabetes Care Rewards program to selected accounts and selected members. And the rationale we have, again, is there's a cost to this, not only the dollar cost, it's also another requirement that you add to the list for the person with diabetes to do. So again, it's that management challenge again. It certainly, from a more positive point of view, does kind of speak to the value of self-management and self-monitoring. I'm a believer in the technology. As I mentioned, do a lot in the technology space. So I believe in the quantified self, the idea that the more that we understand ourselves, our bodies, the physical aspects of our health, the metrics that we now can measure through sensors, the more likely we can manage our health more effectively. But that's effort. It takes time, it takes effort, it takes resources. And we have a team not only that delivers these devices, we have a team on the back end that has to manage the data, right? So you've got this data stream issue, and I spent a lot of time in my work in the Brigham and in the healthcare systems where, the provider community is concerned about these data streams, about how are we going to manage this voluminous amount of patient-generated health data, which blood glucose is one dimension, so that we make sure that we are supporting patients, providing care when it's needed, but not getting overwhelmed. And it really does add another burden to the traditional healthcare system. So you're getting a lot of concerns on my clinician provider colleagues about, not wanting to be inundated with all these data elements. And we need to be just better equipped to manage the data flows and make sure that we're using the data instrumentally to get a better outcome. And again, so for those members who are at higher risk, and where we think they're likely to benefit, we definitely support it. And we do provide coaching, nurse education, feedback when we see higher readings or low readings. And we do that tracking with our vendor colleagues that provide these devices and the strips for management. But it's only one part of the piece of the puzzle. This is a complex illness. You need a comprehensive approach.
Got it. So at Health Action Council, one of our pillars of value is our health improvement activities. And so this next question is, we're talking about the diabetic population here. Are you doing anything upstream with the pre-diabetic population?
Another great question. Yes, we are. We have another program called Healthy Weight, Healthy Heart. And this stems from work that we did at Abacus called the Healthy Weight Initiative back probably 5 years ago now, when really it became very clear that we were facing an obesity epidemic in the United States. And unfortunately, we continue to have it, but it was just peaking at the time, particularly with children too. There was this tremendous recognition that we have a generation that's coming up that could be burdened in ways that we couldn't even imagine in our previous lives, or folks of my generation, because of the burden of obesity that's unchecked. And we know diabetes follows obesity incredibly closely. And that so addressing the pre-diabetic or the person with obesity to reduce the risk of diabetes makes a lot of sense. So we've developed a Healthy Weight, Healthy Heart program that we do for a number of our employer accounts, where we do it both with diabetes care awards for the established diabetics. Healthy Weight, Healthy Heart is really designed to promote the optimal management of weight. And, there's a pretty good evidence base about how to control and manage weight for the long term. And in fact, the big issue is not about what you do to lose weight, what you do to sustain the weight loss. So many things can be done to lose weight, and we've got a host of programs, and we've done many of these over our years with our clients. We've used Weight Watchers, we've used other established vendors for weight management services. We really recognize that the challenge is in the management over time. And actually what we found in the research evidence that the most effective approaches, there are really two components. One is increasing physical activity. So in weight loss, the weight loss period, actually diet is a more important component than physical activity, although physical activity is always important, but in terms of the relative importance, when you get into maintenance of weight loss, physical activity is critical. So we promote physical activity as a major component. And this is where the self-monitoring really does come in. I feel very strongly about this, as we do at Abacus, that we want to promote weighing oneself. So doing self-weighing once or twice a week over time is a really important skill for maintaining weight loss. And the rationale for it is really quite behavioral. it's a lot easier to lose 2 pounds than it is to lose 10 pounds. If you know you've gained 2 pounds, and you may not know that unless you're weighing yourself regularly, you can adapt, change your behavior, reduce those 2 pounds, or stay within a 2-pound range much more effectively than if you wait till you gain 10, 15, or 20 pounds, and then you're back to a major challenge again to go through a weight loss effort and activity. So definitely have that program, do promote it as well. We see it as going hand in hand with the Diabetes Care Rewards program. And we continue to believe that obesity has got to be addressed as a public health problem as well, and not only because of the diabetes risk, but the cardiovascular risk.
Well, Dr. Ahern, that's all of the questions that we had today. And I want to remind everybody again that members of Health Action Council will be able to find copies of the slides and the recording in the Member Center on our website by the end of Monday. If there are any additional questions, yes.
If I could just interrupt you for 1 second, I'm sorry about that. We're actually not going to be posting the slides until the research has been peer-reviewed and published in the journal. We'll have access to the recording, but the slides, we won't have access to the slides for a few weeks. Thanks for a clarification, Rick.
Yeah, thank you, Rick. I'm glad that you said that. I wanted to make sure that participants in the event today realize that yes, we are proceeding to publish this in a peer-reviewed journal because we believe this. These findings are really critical for the field, so that will take some time. But we're moving forward, as I mentioned, with these sub-analyses and the like. And then once we have that done, we can make them available and update the data as well.
Okay, so we will be putting up the SHRM and HRCI poll, and for those who'd like to receive credits upon approval, please respond to the poll. But before I let you go, I'd like to remind you that our quarterly compliance webinar with Christine Poth is coming up at 10 a.m. on Thursday, June 6th. Also, don't forget about our 2-week summer Step It Up Challenge, which begins on June 10th. You can register your team on the Health Action Council website and get in on the fun and the competition with other Health Action Council members. That concludes our session today. Hope that you can attend our next webinar, and thank you. Have a great day.
Thank you.